Here we go. Good morning and good afternoon to everyone. Welcome to another Weber Training teleclass. This is, in fact, the first Healthcare Infection Society teleclass, sponsored by, presented by, arranged by the Healthcare Infection Society, and I am delighted that that we're able to do this collaboration. And we have two experts with us, two people who have both presented teleclasses before, and both presented very, very excellent teleclasses. I'm really looking forward to this. And it's a topic that is of tremendous interest. So I'm going to carry on. Dr. Michael Weibren is going to start, and then Dr. Manjula Meda will continue after that. So I'm going to try to bring up Michael's slides. All right, Michael, you're ready to go.
Okay, is that changing color?
Yes, you're good.
Okay, good afternoon, everybody, and welcome to this lecture. As I said, this will be a dual presentation between myself and my colleague, Dr. Manjula Meda. I hope to give you some of the theory in the first half of this talk, and in the second part of the talk, my colleague will move on to describe some of the practical applications. BEIPI stands for the Built Environment Infection Prevention Initiative, and Manjula will say more about this. So this is the role of the multidisciplinary team in building safer hospitals. If you want to buy a car, and there's probably around the world, there are different safety systems, but in Europe, there's something called Euro NCAP. And there's a way of assessing whether a car is safe. So when you make a choice about a new car, you can go for a safe car or a less safe car. When it comes to hospitals, we talk about safety, and there are various aspects to safety. But what we're going to talk about today is the risk of infection from the built environment, and mainly going to focus on water and wastewater systems. And the first thing to say is we've got no way currently of assessing whether one design of hospital is safer than the next hospital. And when we're assessing safety, we shouldn't be looking at the conditions that people are coming in with. What we're looking is, are they acquiring infections from the built environment? Unfortunately, in the UK, we've had a number of failures of brand new hospitals. And this was the Glasgow hospital. It's part of an inquiry going on. And there were transmissions of infections from the water and wastewater systems to patients, which resulted in patients getting infections, and unfortunately, a number of people dying from these infections. And it wasn't just that the new build went wrong. There's a whistle blowing, and there's been part of the inquiry as to why the actual problems where people tried to hide what was going on. And here's some of the hospitals that have failed in recent years. So there's a Glasgow hospital. In Edinburgh, there was problems with the ventilation, and there's also problems with mold in one of the new hospitals. In Papworth Hospital, there was a waterborne outbreak of Mycobacterium abscessus and Legionella afterwards in the brand new hospital. In 2024, this brand new maternity hospital should have been opened, but it is still not open because the water systems are heavily contaminated with Pseudomonas aeruginosa. Again, the National Rehabilitation Centre, due to open in 2026, has a problem with contamination of the hot water system. And here, this is Aberdeen's new hospital, which again has been prevented from opening. It's going to cost large sums of money to fix this. And this is because of the presence of mold in the building because of water damaged plasterboard. Now, the number of new builds is roughly 170 trusts across the UK hospitals. But if you look at the number of new builds in recent years, this is a very high proportion. But problems are actually worse than this, because what makes the headlines is just the tip of the iceberg. There are many issues in other hospitals not making the headlines. If you're interested in water and wastewater safety, we get to hear of this. There's no database of what's going wrong, and there's no audit feedback built into the system, so there's no learning. So people are blindly wandering from one new build to the next, making the same mistakes. And to validate this, hospital new builds roughly occur into 20, 30-year cycles. So the last cycle of new builds hospitals in the UK is around the millennium. And this paper, what it showed was that Some of the problems in the hospitals were unique to a particular building project, but most were common to all. People were making the same basic mistakes. It may seem incredible to the layman that we can put a patient on the moon, but we couldn't even design an operating theatre safely. And what they said was if these problems are recognized at an early stage, costly alterations and delays, not to mention the clinical risk, could be minimized. Again, this is a paper coming from the United States. This looked at the opening of brand new buildings between the mid-1970s up to about 2018. And this is where there was a waterborne outbreak infection linked to opening the new building. So it included healthcare and non-healthcare facilities. But what the red lines show is that commissioning, wetting the water systems and commissioning is a major cause of failure of water systems. But more importantly, we haven't learned. We're making the same mistakes that we made in the 70s as we're making currently. And as Albert Einstein's credited in saying, insanity is doing the same thing over and over again and expecting different results. So what we have, if you look at this, this is a machine, the design, construction, installation, commissioning industry. And even if we had a good design, if we put it into this machine, what we're getting out the other side is in an unsafe building. And so the system is broken. So we've got two problems to fix. We need to fix this so we get what we want is what we get at the end of the day in terms of patient safety. And the second thing is in recent years, what antimicrobial resistance has revealed to us is the risks coming from the built environment. And so we're seeing organisms, because they're easier to track, because they're resistant, emerging from water and wastewater systems. But what has happened is none of this so far has really translated into widespread change in designs to protect patients from the water and wastewater system. So you can get splashing up to 2 meters. And everyday practices, such as filling a jug with water, filling a clean pulp bowl with water, because they touch the drain, can transmit wastewater organisms. Even a patient having a shower. And these aren't just clinical facing areas. Outbreaks are coming from main kitchens, pantries and ward kitchens. Anywhere where there's water and wastewater services, we may get these transmission of infection. So what I would like to look at is these two things. On the left is a picture from a medical facility in 1850, and on the right is the Grenfell Tower. For those of you who live outside the UK, you may not be aware of this, but this was a high-rise block of flats. One of the flats caught fire, and there was cladding on the outside of the building. And the fire spread dramatically quickly, and it was a tragedy, killing 71 patients. But both of these have some impact on what we're talking about. And there's 3 people I really want to mention today. Hopefully Florence Nightingale is familiar to everybody. Don Berwick is the American champion for patient safety and produced a short report for England. As you can see at the top of it, a promise to learn, a commitment to act. And Dame Judith Hackett led the report into the Grenfell. All of these reports are free to download, and I certain notes on the hospitals, all of them, they're free. And there's certainly the foreword of Dame Judith Hackett's report, as well as the other 2, tremendous insight in them. So Florence Nightingale was born in 1820. She was actually born in Florence in Italy, hence her name. And she traveled widely and learned from medical practices abroad. And the other thing was she was a pioneer in statistics. So she was able to demonstrate the impact. And Notes on Hospitals was what she published in 1858. It almost sounds amateur, Notes on Hospitals, but the insight, as I said, is phenomenal. And what she said, it may seem a strange principle to enunciate as the very first requirement in a hospital is that it should do the sick no harm. And what she said so eloquently so long ago is still as relevant today as it is then. As I've already showed, we're building hospitals which are unsafe. So to put this into modern parlance, it would be place patient safety at the front and center of everything you do. And this is where Don Berwick also says, in an occupied building, place the quality and safety of patient care above all other aims for the NHS. This, by the way, is your safest and best route to lower cost. And what he's actually showing at is if you can see the risks to the patients and mitigate the risks, this is going to be the safest way a most cost-effective way of delivering care. And the same goes for a new build. If you focus on time and money, it's unlikely you'll achieve either because you will not see the risks which produce the delays and cost money. The other thing Florence Nightingale said is that everybody else, it may seem obvious to us, you look at that men's ward, of course people were contracting infections from that. But as she said, it requires a considerable amount of experience in hospitals of various constructions and varied administrations to go beyond this and be able to perceive the conditions arising out of these that have a very powerful effect indeed upon the ultimate issue of cases which pass through the wards. Only she could see this. So she talked about a risk-based approach. And it's easy to see the risks back in 1860, but this is a brand new design, modern design of an ITU. And again, people are walking in and out of that. And for people who can see the risks, you can clearly see there that even the design of the water system isn't safe. And lastly, she demonstrated it's the harm from the built environment. And the good news is, what we're learned about is there are so many infections coming from the built environment that if we get this right, the opportunity to improve patient care is tremendous. So Dame Judith Hackett, she was asked to do the Grenfell inquiry, and the government initially said to her, we want an inquiry looking at the cladding, because this caused a fire. And she said, I refuse to do so. And the government were taken back. And they said, well, why? Well, she said, if I do a report on cladding, in 6 months' time, it'll be another problem with the industry, 6 months after that. And what she said, be it the Grenfell fire, the failing at a new office block, supermarket, or residential homes, or in a healthcare facility, the root cause was essentially the same. And if you can get a chance, read the foreword because it's full of wisdom. And what she said, you have to take a risk-based approach, and blind following of guidance is unacceptable. And this is already what I want to talk about today, because this upsets people. They think we're actually discarding guidance. We're not. It's using a mature approach to guidance, and I hope to explain this. And competence is key. It's both individual competence, but you have to assemble the right group right at inception of the project with all the skills for the task in hand. Otherwise, you will fail. If you don't involve all the people with all the knowledge, it won't happen. And she talked about measuring outcomes. So these are some of all of the frameworks we use and people to build a new hospital or new building. But unfortunately, despite all of these, it's not working. And what we rely on very heavily is guidance and compliance. And the one thing you can say about guidance and compliance is it's got a strong track record across numerous industries of failing. And I hope to explain why. We're not disregarding it. We need guidance, but it's the way we use it. And guidance and compliance blind people to risk. It stops people thinking. Contractors and other people will like it because here we are, you've got a formula, you follow it, and if something goes wrong, you can go to court and say you're protected. But unfortunately, the occupants of the building are not protected if one relies on this philosophy. So here's guidance in terms of water and wastewater safety. There's a plethora, almost too much. Which do you use? Sometimes, if you've involved in writing guidance, the group will actually make perhaps 20 minutes writing one paragraph. And if they can't get this right in 20 minutes, all their background knowledge, how do people understand it? So it's ambiguous. It's out of date. It fails to define roles and responsibilities. We've seen the first wave of hospitals in the UK use guidance which was 10 years out of date because people are used to just blindly following guidance. It does not identify the risks, but most important all, it does not make you competent. If you hand this over to an architect or design team, it will not make them competent. And to give you an example, the Belfast, this was promised a better birthing experience. This is a hospital which is opened. It's going to cost hundreds of millions to actually fix this problem with the water system and now wastewater systems. More than 50% of the outlets were positive Pseudomonas. But this building is compliant. In the UK, we have what we call the Health Building Notes and Health Technical Memorandum. It's compliant with that, but it's unsafe. Similarly here, this is a drug preparation area. We've already seen that water can splash up to 2 meters. You can see this sink right beside the drug preparation area. And this is what they've had to do in a brand new hospital, remove the sinks before it's actually opened. The left is compliant and unsafe, and the right is non-compliant and safe. And people worry about being non-compliant. But as we've already said, you've got to place the safety of the patients or the occupants at the top of everything we do, the forefront. If you had some guidance which told you just walk down the street blindfold and it was unaware of a hole in the street, you'd fall down there. And this is exactly what is happening. If you can't see the risk, you cannot mitigate the risk. And a risk-based approach is essential. So what you do is you have guidance as an adjunct, but you form a team whose job is to think of the risks. They're there to think. And anything else is nothing but an elaborate smokescreen and will not get you to a safe space. We also have in the UK something called the Health and Safety Executive, and this looks at the most common cause of incidents. They involve incidents. And all of these apply across the construction industry: poor management, poor communication, lack of training and competence. And as I said, competence is key to actually identifying risks. So what is competence? It's the combination of training, skills, experience, and knowledge that a person has and their ability to apply them to perform a task safely. And it's a task safely. And we've got to think for the task in hand. And you've got to get this multidisciplinary team. It's not just one person. And also we've got to understand that you may have, for example, one infection control person who's got competence, but they may not have competence in everything. People have to say if they don't have the competence. And it's understanding the consequence of your actions. So nobody wants to cause anybody any harm. But if you don't understand the consequence of your actions, things will happen. So innocent mistakes on a building site, putting some rubbish down a wastewater system so it leads to a blockage, this may result in a patient contracting an infection, but nobody understands the link. There's a hierarchy of competence, and the first stage is unconscious incompetence. This is where you can't see the risks, and many people are at this stage and they think it's safe. And what we need to do is move people to conscious incompetence. They suddenly realize actually they don't have the skills and the impact of the actions on patients. There was one of the most recognized advertising campaigns was something called Ron Seal, and it does exactly what it says on the tin. And so does this apply in a healthcare setting? I don't think anybody would question whether infection control should be involved in a new build. So they're appointed to a project team. Many of them, through no fault of their own, have had no training in the built environment, so they bring no added value, but they tick the box infection control is involved. Are they competent? Of course, they're competent in their day-to-day job, but do they have the expertise in the built environment? We don't ask the right questions. And often what we do is we appoint people by titles, what it says on the tin, not by experience and training. So here was a new build. This was a new hospital program, visit this hospital. And given what was gone wrong in so many of our hospitals, they were pleased to report back that there are no issues with the water systems. And so was this an accurate report? And if you visited the hospital, you would have found that many of the outlets right up against the patient bed, so there's a risk from the periphery of the water system. The main surge stacks were being blocked by the contractors, and even at ward level, when they opened up the drains, they were full of sandwich wrappers and bottles, presumably from the construction site. So it wasn't a true report. And it's because what they meant, there's nothing such as a Legionella overgrowth, but they didn't have the expertise to recognize these problems. And they failed to recognize major issues with the periphery of the water system and the wastewater system. And what's happened is, in response to the built environment, because our standard infection control precautions are not very effective in preventing transmission from water and wastewater systems, we've had to remove water services. And this This has produced confusing nomenclature, such as water-free care. Some people think there's no water on the unit. And there's no mention of the wastewater system, which is really the main driver for change. So people don't tend to look at wastewater systems. This was visiting one hospital, asked them if there's any problem with the wastewater systems. They said no, but they said they'd look into it. And then they found there are more than 800 blocked toilets a year. And it's quite interesting. And what they found, the cause of this, was that the toilet roll dispensers wouldn't give out the toilet paper. So people were using hand towels, which was producing the blockages. So in the UK after the Legionnaires outbreak, we had guidance on Legionella, which is mainly about engineering controls. In 2012, we recognized Pseudomonas. This is the last 2 meters of pipework. And there's this estates bulletin for the first time, and I would recommend a lot of what I'm saying is in here. This recognizes the periphery of the water system now as a source of infection requiring specific training and expertise. So how do you define water and wastewater safety? And this is something which has come out of BEIPI, and we defined it splitting it into 3 areas based on the architecture, the necessary expertise, raising an awareness of wastewater systems, and now this permits articulation, identification of risk. So if you've gone to that hospital, you would look at all 3 areas. So first of all, we need to raise wastewater. This is something where we've got ongoing issues. I've visited hospitals where sewage was coming up into patient showers and people just accepting this as the norm. It isn't. So we've got 3 areas. We've got the main body of the water system. So this is where the water comes in from the mains to the last 2 meters of pipework. The main body of the wastewater system, which extends from just beyond the waste trap to where the waste drainage or the sanitation enters the municipality, and what's in the middle. So the last 2 meters of pipework, connected devices and connected systems, and the waste trap. The science behind the main body of the water system is much more established, but as we've seen, we're still having major issues with water safety. The wastewater system hasn't been updated for 50 years and is not reflecting what we're learning through AMR. As I said, the new HTM recognizes this as a specific area for the first time. The periphery of the water and wastewater system is a source of the vast majority of transmission events. And both of the main body of the wastewater system and the periphery, human interaction can have a major impact on safety. We know from some studies that clinical hand wash stations, only 4% of visits to the sink are for the right purpose. 96% of the visits are for the wrong. Blockages of the periphery of the water system and the main body, again, impact on patient safety. I just mentioned, and as I said, risk underpins each area. I just mentioned briefly the CLEAN study. This showed, this is decontamination of medical equipment at ward level. It showed that if you did it properly, you could get a 34% reduction in healthcare associated infection. Why this relates to the built environment is A, water's being used and there'll be contact with drains. And secondly, when we do contamination at ward level, rarely do we provide a system from flow to dirty to clean. So items, even if they're clean, become recontaminated. And again, just for water, other routes of water in, there may be devices which are filled from the system and wipes can bring water in. So water safe, there's lots of guidance, training, competency, but things go wrong throughout the design, construction, installation, commissioning process. And what happens if you look at construction installation, many of these people are working out in office blocks and there's poor practices out there, but there's because they're dealing with people who are otherwise well, we don't see the risk of infection. You come to hospitals, it's different, but they haven't changed their practices. They don't realize the risks. The main body of the wastewater system, as I said, hasn't been updated for 50 years. We need to develop expertise and mitigations. And this is the wastewater system is a major source of driver of AMR, both within hospitals. It's a superhighway, but it's also pushing AMR outside of hospitals. And lastly, what I call clinically integrated water and wastewater safety. This is the periphery of the system. And as Manjula will tell you, we need to work with clinical teams to develop mitigations. And it's not just the patient-facing areas, it's everywhere. So if you're looking at kitchens, we need to work with the kitchen staff. Anywhere in the hospital, we need to produce changes which not only will reduce risk, they will save money. So this is just giving you some of the, looking at the different areas. But I hope what this first of all shows is that people think you can get an architect and design team, they'll build you a safe hospital. At one stage where you put a sink, that may be an aesthetics, an architect could have designed that. But we now know whether you put a sink in makes a difference and where you place it makes a difference. And the architect hasn't got the understanding, why should they? If you say to a design team, design me a water system, they'll design you one. If you say to them, design me a safe water system, they won't know where to start. And we need all of them. They've all got the skills, but we need to have this multidisciplinary approach. And it's got to be right from inception of the project if it's going to work. And here, so again, the support services need to come in designing these areas. So what we're trying to do is all of these risks may occur anywhere. But if you went to any of these hospitals and said to them, would you like to turn back the clock? If you could identify all these risks and issues at the inception and put the mitigations in place, so you front load the project, hopefully none of these things would have occurred, which cost time and money. And the longer they occur in the process, they cost more money and you may not be able to fix them. So we're trying to identify the risks from inception. And what we can't do is, we can't put all of these risks onto contractors. They will run away or they'll charge you more money, but they don't have all of the people with the necessary skills to solve this. So what we need, no longer is it architects, design teams and guidance. This will not get you to a safe space. You have to have right from the beginning, the mixing of all the groups, the multidisciplinary team. So you need to do your risk assessment, who you need, and then you have the ability to see the risks throughout the process and put in your mitigations. And this is what's called a project discipline specific safety group. It's mentioned in that the NETB, which I mentioned. You should have a clerk of works. This is somebody who works with these and then goes and checks on the building site that everything's being done. And so there should be a supportive learning environment. Nobody knows everything. And I think what we're worried about is, since the Hackett report has come about, it was released in 2018, none of the stakeholders have stood up, have come to the table. It's now requiring legislation to drive this through. And if you're forcing people to do it, it's not going to work. And they should be interested, because for companies, this is going to save everybody time and money and make them the best. Thank you.
Thank you, Michael. Thank you very much. Just trying to get Manjula's slides here.
Can you see my slides, Paul?
Well, no, I can't. Can you try one more time, please?
Yeah, okay. Try. Okay.
Now, I see something happening.
Is it projecting now?
Give me a moment. I'm sorry. Here's what I can do. If you'd like to stop sharing.
Yeah.
I have some slide. This is a slide set that we had in our system.
Okay.
All right. Let's try this. My apologies.
No worries. Shall I use this set?
Yeah. Just use use the right arrow on your keyboard to move the slide.
Perfect. Okay. So, hello everyone. My name is Manjula Meda, and I think that was a very good introduction from my colleague Dr. Weibren into multidisciplinary team working and how this is so important to build safer hospitals and the BEIPI initiative and an introduction to the BEIPI initiative. What I will talk in the next few minutes is about a practical example on how you can put all of that to practice, especially when you're trying to combat AMR. So what we have already learned, what Dr. Weibren so clearly showed is that within the healthcare environment, AMR is showing us that there are routes of transmission from wastewater systems to patients that we previously didn't recognize. And one of the inadequacies also is because our surveillance systems have not been good enough to track these bugs from wastewater reaching patients. And also, I think another point to remember is the risks from water and wastewater, like Dr. Weibren clearly showed with those three different aspects of water and wastewater systems are very clearly different. And you need different strategies to tackle those things, or different risk assessments to tackle risks from water, wastewaters, and the periphery. Okay, so this is if you look at CPE themselves, so CPE, for those of you who are not microbiologists, are carbapenemase producing enterobacterials, which are one of the most resistant bacteria that we find in hospitals, transmitting to patients. And at Frimley Health, the hospital where I work, we have universal admission and discharge screening for all patients, which means we detect all patients coming into hospital with CPE. We also detect all patients being discharged and may have acquired CPE during their admission stay. And what we found in the 7 months of data that we analyzed when we did universal screening is that, as in the blue bars here show, patients in augmented care were only a very small proportion, about 12% of patients who were picking up CPE carriage. Travel was associated with 22% to another country where CPE is endemic, or another hospital within the UK. But patients who had ulcers or long-term catheters had about a 25% risk in acquiring CPE during their hospital stay. But what was remarkable was 51% of patients, so more than half of all patients, had no risk factors at all. So that, and then when we looked at CPE outcomes itself in our own hospital, out of 253 patients we looked at who had acquired CPE, either in hospital or in another hospital, 58% of them went, that is nearly a quarter of them, went on to develop an infection during the same encounter or the same admission episode as when the CPE was detected. And all-cause mortality at 6 months of the first CPE detection was about 27%. And this is very similar to another study that shows similar results. And other studies also have shown that the mortality rates with CPE is at least twice as much as it is for sensitive enterobacterials. So there's significant mortality associated with these infections, as we all know. So some of the myths that we have to dispel, especially around resistant gram-negatives like CPE, are that the risk of acquiring these infections are only for augmented care patients. It clearly is not. That the majority of cases originate not within your own hospital, but elsewhere. Again, this was not the case in our hospital. And the risk, and there is this misconception that risk only involves colonization risk only, and very few patients go on to develop infections. Whereas in our case, and as in many other studies now show that at least 10 to 30% of all patients go on to develop infections, and the infection and mortality is uncommon. So these are the myths that are associated with this, and we had a strategy to try and reduce these acquisition of multi-drug resistant organisms within our own hospitals. And what we call this the water and wastewater safe strategy or environment. And what this needs is like a systematic strategy which involves, hold on, let me just try this. Okay. So it involves a lot of preparation, because what you're trying to do is trying to bring about behavioral culture change across an entire organization. And in our case, it's a very big organization, which I'll show you later. It needs time. It needs multidisciplinary team working, which is the focus of this talk, but also a holistic approach. You need people from the board to ward involved. You need to take, you just can't look at wastewater, it's water, wastewater, perhaps ventilation when you're looking at entire design of your refurbishment or new build areas. You also need to take into consideration clinical risks, not just IPC risks. And obviously things like sustainability are also very important when you're redesigning hospitals. And our strategy involves multiple steps. The most important was education. And it was this means educating yourself on what the risks are, like Dr. Weibren very clearly explained, learning from other centers. We traveled to other hospitals, including the Netherlands, to learn what was happening there, and some of our own centers here in the UK. And working collaboratively, which I'll show you, which is the most important bit, risk assessments, which we have seen, and then developing your own business cases, designing and innovating and implementing. But also what is important is trying to set up what your surveillance parameters are going to be, so you can track these changes and evaluate outcomes once these strategies are embedded. So this was a multidisciplinary team we put in place to develop a water and wastewater safe strategy in our own hospital. Obviously, the clinical teams are the most important because it affects how they work, and they need to be convinced that these changes are possible and it can be implemented within their areas. So letting them take the lead helps bringing about that behavioral culture change, which is the most difficult aspect of all of these changes. When we are talking about changing the way the designs of hospital and in improving water and wastewater safety involves. Obviously, there's IPC teams, there's capital projects. These are the people who drop the designs or get contractors employed in the hospitals. Your estates and facility teams. In the UK, we have what are called water and wastewater safety groups. And these involves, again, multidisciplinary teams within our own hospitals, but also experts from outside. And architects and contractors who are not actually employed by the trust at all, but are brought in from the outside. You've got to work very closely with your executive teams and boards, because obviously they are the ones who take in the UK, they take responsibility if things go wrong. Procurement teams, comms teams, patient experience, very important to involve patients and visitors and staff equally. Obviously, lab services and epidemiologists, like I said before, sustainability and efficiency leads. And in our case, because we were one of the first trusts to do this, we had to get a lot of external support from national organizations like the New Hospital Program, NHS England, Healthcare Infection Society, and a lot of national and international experts helped us achieve what we were trying to do. And so just to give you a background, so Frimley Health NHS Foundation Trust is one of the largest acute secondary care hospitals in the southeast of England, in Greater London, and it has 1,800 beds across 3 acute hospitals on the top there, with about 14,000 staff. So bringing about, like I said, the organizational culture change is not easy when you're talking about 14,000 staff, and it serves a population of about 900,000 people. And this started all in one of the acute hospitals, which is an 800-bed hospital called Wexham Park Hospital. And the background to this is that we had a polymicrobial CPE incident. So we'd had multiple clusters or small outbreaks for many years, and we were seeing a small but steady increase in the number of CPE acquisitions in the hospital. And we knew that, obviously, from all the evidence that was building up at the time, that there was an association with transmission from wastewater systems. And this was a very old estate, and there was a range of sanitary ware and decontamination spaces which we knew were not satisfactory, and we wanted to update these designs. And obviously, we knew that we needed multidisciplinary, multi-organizational team working if we had to achieve what we needed to. And like I said, being the first hospital, one of the first hospitals, an early adopter of these changes, brings in itself unique challenges. So this is where this is London, and those are the three acute hospitals just outside of London. And Wexham Hospital itself was built in May 1965, so nearly 61 years old, and it was one of the first purpose-built NHS hospitals. after the war. At that time, it in fact had a Royal Institute of British Architects Award for functionality and integration. And what I'm trying to say, and we have older hospitals in the UK. So Bart's Hospital, for example, is 903 years old. But the point here is that it doesn't matter whether it's a new build or an old build. And Dr. Weibren showed many new hospitals where they've had problems. If you do not integrate water and wastewater safe principles in these hospitals, you are going to have a problem, and it's possible to bring about change in older hospitals as well. So these are some pictures to show you examples of what we did. So the water and wastewater safe environment in the ICU, it was a 16-bed ICU in this hospital, and we went from having a hand wash basin at the end of every bed. So you can see it was within the 2-meter splash zone of the patient environment and patient itself. We went from having 23 to 5 hand wash basins, and there was a period of time when these were taped off, so staff could get used to the concept of not having a hand wash basins, but also the move from washing hands to using alcohol or other type of hand sanitizer was not very easy. So the staff led on trying different types of hand sanitizers, and what they ultimately found was there was actually better compliance. And if the feedback was that their hands were better hydrated, and it was in fact easier to use than having to wash your hands every time they had contact with the patient or the patient environment. There was we also had a lot of other design aspects integrated. So we needed to figure out how we are going to get clean water for washing patients, and this was one of the design innovations from our capital and estates teams. This is we call it the Frimley faucet, but what it essentially is a tap which has a filter fitted on with sterilizing grade water coming out of it, and it's operated through a sensor system. So there's no contact with the drainage system here when you're collecting water, and the water itself is safe because you have a filter that you can be assured it has good quality water coming out. And this is the similar type of water that we use in the kitchens as well, where we have a pressure operated tap where you can get sterilizing grade water through these outlets. So it's also sustainable, and this is why this approach has been used in our trust. And then again, these are design aspects that we've incorporated into hand wash basins. This is custom made sink where the drain is offset, and there are no nips around the drainage system itself where bacteria can hide and increase the splashing risk. And again, here this was a shower where the patient used to actually sit on top of the drain, but we tried to offset it as much as we could, so the splashing risk is reduced. And one of I think the greatest benefit in reducing healthcare associated infections in the hospital, not just intensive care, was the prototype that we created for dirty utilities. As you can see, previously there was no demarcation between clean and dirty, so nurses or other staff would come in with a bowl of urine or feces, and they would leave it, for example, on the counter there, where if the macerator was running, which means there was risk of other clean stuff being contaminated. So we changed all of that to move from a dirty to a clean design. So staff, there are 2 doors, so you come in through the dirty end. You deal with the contaminated stuff in the dirty area, wash your hands, and then decontaminate it with alcohol or other sanitizer, and then you only take the clean stuff into the green end, and then you come out of the green end. So it's a one-way system, and the doors are automatically operated, and it's very, very little room for error in such a design. So what this actually does, it drives change beyond infection. So staff found it much easier in terms of many different things. It was quicker for them to find things and do their jobs. And it can go beyond healthcare as well, so into the community and other types of settings. And this was our drug treatment rooms that we are changing in an old building. So here, as you can see, the risks are very high. Dr. Weibren's already explained there's a splash zone, and you can see there's so much equipment around this. So but just by removing the sink, we have addressed many of these risks of contamination. So it's not just design that will work. So you have to incorporate change the design, but also your practices have to change. For example, in our endocrinology wards, what we saw the practice of washing ulcers in near showers, and these patients were acquiring CPE at a very high incidence. So when we then moved to using sterile water for washing wounds, and personal hygiene, obviously there's many different options for this. Like I've showed, you can use the Frimley faucet, or there are other options with wipes as well. And for decontamination of equipment, rather than washing them with water and storing it next to a sink, the wipes may be an option, but there are obviously other options that can be explored. And very reassuringly, what we have found, I mean, this is a very complex slide, and I'll try to go through this very quickly. The gray bars at the back show you how much screening we're doing. So with universal screening, as you can see, since 2023, we've been doing quite a lot of screening. And the blue bars show how many people are picking up colonization rates. And at the maximum, this was about 4 patients picking up CPE per day. And this is now reduced to in the last week, we have had no cases picking up CPE for a 28-day period. So the blue bar shows the reductions in colonization, and the red line shows the reductions in infections. So increasing surveillance will show you that you are actually detecting more, but once you put in your interventions, you can reduce both colonization and infection rates. And this is our hemato-oncology ward, which shows reductions in both new CPE acquisitions once hand wash basins were rationalized, also reductions in sensitive Pseudomonas infections that were patients were acquiring in hospital. And this is older patients ward, again, reductions in CPE cases once we rationalized hand wash basins, but also reductions in C. diff infections in older patients ward. And one of the questions we get asked is, why do you see reductions in C. diff? And this is intensive care data where we show reduction in VAPS, Pseudomonas, and gram-negative bacteremias. The first one is the Stenotrophomonas, the graph, and there is also reduction in VAPS by about 50%. And one of the questions we get asked is, why do we see reductions in C. diff when you are actually reducing the total number of hand wash basins? And I think one of the reasons is because obviously you reduce the total number of infections, so there's less hospital-acquired infections, you're using less antibiotics. And the most important reason is, I think, because our hospital designs have reduced the clutter, the design is better, so you're reducing contamination rates of your environment so much so that the spores are now not as contaminating the environment as they used to be. So just moving on to some of the challenges of all of these of this type of work, especially if you're in a country where this type of work is going to be undertaken for the first time, or you're one of the early adopters of this type of work. I think the biggest challenge will be to get an organizational understanding of the risks. And this is not just like a one-off thing. It needs continuous investment into education, because as you can imagine, you'll have high turnover of staff from ward to ward. So all of these staff members need to be educated, as well as patients and relatives. And within the UK, as Dr. Weibren explained, we have a huge set of guidelines. And how do we derogate? I mean, derogation seems like a not so good word, but when you're improving your hospital designs from a safety perspective, there can be many challenges if you're doing it for the first time, because this is people are worried that you're derogating away from national guidance. So this needs to be very closely risk assessed, and you have to have all the documentation and support ready to explain why you're doing such work. And then obviously, any external contractor, architects who come in to do the work in your area, they need to understand these concepts, because it's all sometimes very new for them. And for them to grapple with these changes can take time. Funding, of course, is important, but as we know, CPE infections themselves cost hundreds of thousands of pounds to treat each infection. So if you do a business case, you can easily balance the amount of funding you need for your design improvements versus amount you're already spending to manage CPE cases. Again, think about bed capacity. For example, when we did the work, we couldn't close many of the beds because the hospital was full. So we had to find a way to work around that. And then also we have to think about establishing long-term supply of products. So the hand sanitizers we use, we had to be 100% sure that we would have supplies of them and we wouldn't run out. And some of it is trial and error, trying to, giving the staff the time to be able to choose what they want to use and maybe change their solution if they find that that's not compatible with their practices. And you need to also be ready for external scrutiny if you're one of the early adopters, because there'll be a lot of questions on why this needs to be done certain way and so on. But the benefits are huge, like Dr. Weibren's already explained. The patient, obviously, the most important is the benefits to the patient itself and the reductions in AMR. There is also a lot of savings. And the good thing about this project is such projects is that you're not only saving lives, but you're also saving costs to your own hospitals in terms of construction, reducing treatment costs, reducing, for example, maintenance of a sink itself can cost anywhere in the UK at least about £1,000 a sink per year. And obviously there's costs with water, costs with reducing the wastewater blockages and so on. There's also, importantly, the sustainability costs that the trusts will probably see. So there's huge amount of savings in the amount of water we use, change from pulp products to reusable stainless steel products, less chemicals for decontaminating sinks, and all the remedial works that are necessary probably will be reduced as well. And we've shown definitely in our hospital sites the number of blockages have significantly reduced since we've undertaken such work. And clearly this is speedier time to construction, and getting it right the first time saves a lot of money in terms of litigation, future building costs, etc. We also did a significant staff and patient survey, and what it showed was, although there is usually a reluctance in the beginning from some staff to adopt these principles, overall majority of staff felt that this was a good thing, especially when they see the patient outcomes, and that this is not such a big issue, and that it works, and that it brings about better teamwork and safer ward environments, and better IPC practices, and that it improves patient safety and hand hygiene. So, and this was very similar to the patient feedback that we got. So in terms of this is my last slide in terms of the presentation itself. So what we're trying to really say is that a holistic approach to water and wastewater safety is possible to implement both in existing and new builds, and it's got the potential to change drive change beyond infection and beyond healthcare itself. So just a couple of initiatives that the Healthcare Infection Society is doing. So we've got they've got two special interest groups through the Healthcare Infection Society: the SPARK, which is very research focused, and BEIPI, which is building safer hospitals, and we're bringing together all those involved in building hospitals, from architects to contractors. And although BEIPI has been very UK focused so far, we are planning to sort of try and launch this in Europe. Some of my colleagues, especially Dr. Joost Hopman from the Netherlands, is driving this change in Europe and maybe to other parts of the world as well. And we are working with other similar organizations like the Scottish branch and WHO. And that's the QR code for BEIPI. If you want to be involved, please sign up. We'd welcome your participation in BEIPI. And this is another course that Dr. Weibren, myself, and a few other specialists in the UK run. And it's actually got global specialists who take part as facilitators. And it's called the Water and Wastewater Safety course run by the Healthcare Infection Society. And that's the QR code if you want to express your interest to be for the October 2026 course. Yeah, and this is just about his membership. If you're not already a member, please do join his, because we've got several advantages for members. And I think that's the last slide.
Yeah, I can jump in there. Thank you very much. That's a great place to end. And I must say, I've been a member of the Healthcare Infection Society for a very long time. And on top of everything that it does, the journal, lovingly known as the Green Journal, but the Journal of Health of Infection Prevention, is, I think, my favorite one. Some fantastic papers. And if you are not a member of the Healthcare Infection Society now, if for no other reason than access to the Green Journal, I would encourage you to to join. It is a fantastic organization and a fantastic group. In just a couple of minutes we had left, I wanted to ask both of you, the rise of fungal contamination in hospitals and healthcare settings, is that changing anything? Is that changing the way we approach anything, because they're just so hard to get rid of?
Mike, do you want to start?
It is changing. I think, I mean, just briefly, if we're talking about new builds, there have been several issues in new builds relating to this. And just to give you some examples, in the Glasgow building, the ensuite, so a lot of our hospitals now in the UK are 100% single room occupancy with an associated ensuite. And they had big problems, and this is happening in other hospitals, where the lining of your wet room is terribly important. It's just as important as the sink and other. This was not adherent. It was allowing water to go behind. This was producing fungal overgrowth and resulted in transmission of infection. Again, as I showed in that one hospital, plasterboard got wet somewhere during the construction process. So we've got many more immunocompromised patients, and we know these spores are in the very fabric of the building. All you need to do is add water, and we will have problems. So it also relies on better design of ventilation in specific areas as well. But I think you're absolutely right. I think there are at least 3 or 4 ongoing issues now with mold relating to new project hospitals because of areas of the hospital getting wet, either following construction due to poor workmanship or prior to it getting wet during the construction phase and installation.
The other question that I want
just to add as well.
Yep.
Sorry, is also the problems that we're facing in the UK and elsewhere with the Candida auris, I guess, is also a multi-drug resistant Candida. And again, survives in many reservoirs. I mean, and the problems are probably very similar. So once you do these design changes, improve the clean and dirty workflows in dirty utility suites, reduce the clutter, it's much easier to get on top of the environmental contamination and risks from the built environment.
Yeah. The other thing that I wanted to ask was the HVAC systems. There, obviously, you can't climb through the vents for the most part. and I, as I found out once, hospitals use their hallways as the cold air return. So it's very difficult to control what is going into a system and thus what's coming out. Is that a bigger factor in the way hospitals are being designed and built?
I don't know if you can answer, Manjula. I'm afraid water and wastewater is my main area of, I don't know if I can call it expertise. You're asking things which I can put you in touch with other experts, but I'm afraid it's not my competence.
Yeah, I mean, it's not. Neither am I a ventilation expert, Paul. But I think ventilation is equally important. Is all I can say. As important as water and wastewater safety. But the guidelines around ventilation within the UK have just recently been updated and much more. What can I say? Easier to follow and I think up to date.
Right. Yep. Well, thank you very much for that. And thank you both for presenting this. It's been a very, very useful and very practical lesson, I think, in healthcare facility management. If anybody has a question, they can direct it to the Healthcare Infection Society, or if you wish, you can send it to me and I will forward that on. There are 3 teleclasses in this slide. The one at the bottom is the one in our Australasian series, and that will be very interesting. And of course, most of you perhaps will know Jules' store. Is Infection Prevention and Control Guidance Fit for People? the case for compassionate, person-centered IPC. Now, this is something we don't look at very often, so I'm so very pleased that Jules is able to give this talk. And I want to thank our patron sponsors, Diversity, Virox, and Gamma, and mostly I would like to thank the Healthcare Infection Society for having this idea and for organizing it and for frankly doing all the work. So thank you to all of you. We'll talk to you again very soon, I hope. Goodbye for now.